Hello, everyone. My name is Jessica Porras, and I'm the Senior Manager for Education and Outreach at CAQH Core. We experienced technical difficulties last week when we hosted this webinar live, so we're providing you with a recording of the presentation. This webinar is focused on the topic of attribution, and we are happy to have a speaker from the National Quality Forum join us today and share her expertise. Next slide, please. We will start off with an update of CAQH Core's BBP initiative, followed by our featured presentation from NQF. Next slide. And now I'd like to introduce our first speaker, Erin Weber, CAQH Core Director. Erin?
Thank you, Jessica. I'm going to start the presentation off with a brief overview of CAQH Core and some of the work that we've been doing in the value-based payment space, and in particular, talk a little bit about why provider attribution has been a topic of interest in our work. As a way of background, CAQH Core is a nonprofit alliance of multi-stakeholder organizations that have come together to develop operating rules for healthcare business transactions. Operating rules are really the business rules that describe the how, what, and when of data sharing between different trading partners. We are designated by the Secretary of Health and Human Services as the National Operating Rule author for rules mandated through the Affordable Care Act. We are governed by a multi-stakeholder board of directors that includes health plans, providers, vendors, and associations. We really see our role as not just an operating rule development entity. We have about 130 organizations that participate in our subgroups and work groups to develop and vet and debate operating rule requirements, but we also see our role as driving adoption and measurable impact in the industry. And we do that through our education and outreach programs like this and our certification program. If you're interested in learning more about the work that we are doing, feel free to reach out to us at core@caqh.org after the presentation today. A couple of years ago, the core board members recognized that some of the challenges they were experiencing at their organizations as they were beginning to implement value-based payment arrangements were very similar to the challenges with the fee-for-service transactions that CORE was originally developed to address. Providers and health plans were using different processes and procedures and methodologies for sharing and exchanging data, creating a lot of inconsistency in the market. Out of that work, we did a series of interviews and research across the industry to identify what are the real operational challenges to streamlining adoption of value-based payments. That work resulted in a report that we put out earlier last year, identifying 5 opportunity areas. I'll quickly cover them here on this slide. The first is data quality and uniformity. Having standardized and uniform agreement on definitions and code sets and identifiers will go a long way to creating some consistency in value-based payment information exchange. Interoperability, developing common processes and expectations for how information is shared between stakeholders. Patient risk stratification, promoting collaboration and transparency across the various models. Quality measurement was another topic that came up, not a topic that CORE will likely address because there are really great organizations already working on these challenges like NQF, but the challenge was heard so many times throughout the research about the multiple measures and lack of consistency in how the measures are used that we included it in the report. And then the 5th area is provider attribution, and I'll talk more about that in a second. As part of our work on value-based payments, we are launching an advisory group of senior level leaders from the industry actually next week to help identify among these 5 opportunity areas really more detailed opportunity areas where CORE could begin to develop operating rules or other solutions to help the industry streamline value-based payment operations. The work that we are focused on really spans the spectrum of value-based payment models. I think the industry is not close to a point of coalescing around a single approach to value-based payments. And so we wanted to make sure that these opportunity areas will have an impact regardless of the model an organization is using. Attribution itself is a methodology to assign patients, encounters, or episodes of care to a healthcare provider or practitioner. An attribution methodology seeks to accurately determine the relationship between a patient and his or her team to ensure that the correct entity is accountable for the patient's outcomes and costs. So in some of the research we've been doing most recently, we've really been looking at the variations in the revenue cycle, the healthcare revenue cycle, from fee-for-service and value-based payments. And what we found is that the process is generally similar across fee-for-service and value-based payments, but there are specific points at which stakeholders need different information, different data at a different time. And those are the places where we think there are real opportunities to have an impact. Health plans may prospectively identify patients for attribution or retrospectively identify them through prior year claim data. And on this slide here, we have two examples of potential opportunity areas and challenges where common approaches may help improve some of the challenges with provider attribution. So an example is that even when patients are prospectively assigned, the provider may not know that a patient belongs to their population until well after the patient encounter occurs. And that's a missed opportunity for the provider to maybe address or collect data that is critical to that patient and that population. The second challenge is determining attribution. So while retrospectively assigning a patient to a provider can ensure an existing relationship, it can still be difficult to determine primary responsibility to a patient's health. So the example here is the diabetes patient who primarily sees their endocrinologist on a more regular basis than, say, a PCP that may have been assigned by the health plan. I'm not going to get into the details on this slide, but this is a more detailed example of a use case looking at the differences in the fee-for-service versus the value-based workflow. Looking at the need for providers to have information on patient coverage in real time. With value-based payments, providers need this information, but they also need to know whether a patient is attributed to them prospectively. There are some current technology solutions, and we think business solutions such as operating rules could really create some more uniformity and common expectations around this challenge. So the next steps for our research, as I mentioned, we will be launching the advisory group of about 12 organizations, providers, plans, vendors, and other advisors, including NQF, over the next couple weeks. That group will identify specific opportunities and strategies that then a core subgroup, and from a subgroup perspective, any core participating organization, those 130 organizations I've mentioned, anyone from those organizations is welcome to participate in the subgroup. And that's where the real requirements developing and business case vetting will occur. So if you are a core participant, keep your eye out for a call for participants later this year. If you're interested in becoming a core participant and engaging in this work, please do reach out to us. And now I would like to introduce our guest speaker, Ashley Wilbon, who is a Senior Director at the National Quality Forum. Ashley has been with the National Quality Forum for almost 10 years and is also a trained nurse practitioner. Thank you, Ashley, for joining us today, and feel free to begin when you're ready.
Hi, and thank you for that introduction. Thank you, everyone, for joining to listen in today. I'm excited to share our work that we've been doing at NQF around attribution, and we'll go ahead and dive in. So next slide. So our agenda for today is pretty straightforward. I'll give a brief overview of NQF for those of you that are not familiar with our organization. I'll talk a little bit about the current landscape and policies that have brought us here today, and then we'll dive into an overview of what we've been doing at NQF to try to provide some guidance to the field around attribution. And finally, I'll leave you with a few key takeaways and where we plan to go from here. Next slide. So the National Quality Forum, or NQF, we were established in 1999. We are a nonprofit, nonpartisan, membership-based organization that is recognized and funded in part by Congress and entrusted with the important public service and responsibility of bringing together multiple stakeholders across the public and private public and private sector to reach consensus on how to measure quality in healthcare and to improve the nation's approach to providing healthcare to its population and making it safer and more affordable. So as a forum, we have about 420 organizational members, and our members span various perspectives, including hospitals, medical groups, health plans, patients and consumers. We also have public and community healthcare agencies that are members, and we also work with various federal agency partners like CMS, AHRQ, CDC, and HRSA. So because we are a forum, everything we do is transparent and open to the public. We are open to public participation, and all the materials that we produce as part of our projects are accessible on our website. So feel free to peruse our website as well if there's anything of interest for you there. We also do work in several other areas to advance our mission. So our first and kind of primary bulk of work is around performance measure and endorsement. We bring together stakeholders to review and endorse performance measures to determine which ones are the gold standard for suitable use for accountability programs. We do this through our consensus development process, where we convene stakeholders through an open nominations process to bring them around the table to discuss measures around our evaluation criteria. We also convene stakeholders through our measure applications partnership to review measures that CMS, or the Center for Medicare and Medicaid Services, is considering for implementing in their public reporting and value-based purchasing programs. We call this the pre-rulemaking process. And finally, we do work to explore and provide guidance on emerging issues in measurement science. One example of this is attribution. So you might even think of us somewhat as a similar organization to CAQH in that we focus on standard setting, but more on the clinical healthcare quality side. Next slide. So in terms of the current landscape, with current healthcare payment reform, there's been an impetus to move the system away from fee-for-service payment to alternative payment models, and has highlighted the need to better understand how patient outcomes and costs can be accurately attributed to a unit within a system to increase unit in the system to increasingly build on shared accountability. With that, we need a mechanism for linking patients to an accountable entity or multiple entities. This is particularly important as value-based purchasing programs shift the focus of care from the individual to the population, and care for a single patient often spans multiple providers. So some of the mechanisms that are used to employ attribution include program-level attribution, in which programs are designed specifically such that the program results of the measures within the program are attributed to a specific specialty or setting. So one example of this would be the hospital value-based purchasing program, where all the measures in that program are attributed to the hospital. With measure-level attribution, this involves the specification of a specific quality measure, performance measure, such that the measure results are attributable to a specific entity like a clinician or a physician group, for example. And on the most granular level, attribution can also be assigned at the visit level using macro relationship codes. So as a part of the MACRA Act, as part of MACRA, which was passed in 2015, it said that as of January of 2018, clinicians can voluntarily submit billing code modifiers that enable the clinician to designate or signal the extent to which they are responsible for the various elements of a patient's care. So while this is currently voluntary, ultimately, the attribution of responsibility will be used to assess clinician performance, which will probably be tied to reimbursement at some point. So next slide. So this table illustrates the framework that HHS has adopted that categorizes these payment models across a continuum. So they have set a goal of tying 90% of all traditional Medicare payments to quality or value by 2018. And so value-based purchasing includes payments made in categories 2 through 4. Categories 3 and 4 are considered APMs, or alternative payment models. And moving from categories 1 to 4 involves two shifts. The first is that increasing accountability for both quality and cost as you move across from categories 1 to 4. And secondly, you'll see a greater focus on population health management as opposed to payment for specific services. So just a little bit more detail about each of these categories. So in category 1, this is strictly fee-for-service with no link to payment, no link of the payment to quality. In category 2, you have fee-for-service payments with a link to payment for quality. So in this category, providers are still paid for each service they provide, but the payments are ultimately adjusted based on quality. And this may include payments for infrastructure and operations, pay for reporting, rewards for performance, and rewards or penalties for performance as well. In category 3, you have alternative payment models that are built on fee-for-service architecture. So this would include alternative payment models with upside gain sharing, that may be a percentage of any net savings that is given to the provider or the APM. And this provides share not only in the gain of potential savings, but also in the risk of excess costs. So the most important distinction I would make between categories 3 and 4 is that category 3 models are eligible only for a portion of the losses on the savings they generate. And with category 4, it's focused primarily on population-based payment, which involves a single payment that encompasses a broad array of services. And this may include a payment for comprehensive population care, and they're structured in a way that encourages providers to deliver care within a defined overall budget. Next slide. So let's bring this back to the patient, the reason why we're all doing this work, okay? We have Ms. Smith here. She has a primary care provider, but sometimes when she makes appointments, her PCP is unavailable, so she sees a nurse practitioner, a PA, or other physician in the office. In January, Ms. Smith develops pneumonia and is admitted to the hospital. Later in the same year, after she's recovered, she decides to have an elective hip replacement, which was followed by a skilled nursing facility visit, as well as physical therapy. So when you look to calculate Ms. Smith's healthcare costs and outcomes for that year, you can imagine that it would be challenging to determine which of her providers are accountable for which portions of her healthcare outcomes for that year. Next slide. So this slide further illustrates the reality with some real data of how multiple providers caring for Medicare patients specifically can complicate attribution. So in the first chart, you can see that across all Medicare beneficiaries, on average, they'll see 5 specialists and 2 PCPs. And for those that are the sickest, that number grows to 8 specialists and 3 PCPs. Next slide. So what is attribution? So that was already presented earlier in the presentation, so we won't spend a lot of time here, but essentially it's a methodology that's used to assign patients, encounters, or episodes of care to a healthcare provider or practitioner. Next slide. So these shifts in the payment landscape that I described earlier have brought attribution and the importance of having the right measures to the forefront of NQF's work. Both public and private sector purchasers continue to look to value-based purchasing and alternative payment models to drive improvements in cost and quality. At the same time, we've seen an increased desire to move beyond simply measuring how we'll perform on processes, but also to assess healthcare outcomes to those measures on those measures for purposes like value-based purchasing and public reporting. So the use of these measures for high-stakes applications, like for payment and shifting to outcomes and that occur and unfold over longer periods of time and involve multiple providers raises concerns about how we can fairly determine who to hold accountable. So as the system transforms and if our efforts are to be successful, it's really important that we figure out how to attribute fairly and accurately using performance measures. And attribution is really the building block to be able to do this using quality measures and performance measures as the building blocks to value-based purchasing and alternative payment models. Next slide. So why does attribution matter? And that brings us to why we are here today. Why does all of this matter? So attribution matters because we have a need to fairly establish accountability to providers who have the ability to take the actions that are needed to improve quality and lower costs, and to understand how to use attribution in an environment of shared accountability. Next slide. So concerns have risen as stakes have gotten higher, which basically means there's money involved, right? So anytime there's money involved, there's certainly efforts that are being made to make sure that we're doing everything we can to meet the standards needed to get payment for the services that are provided. So some of the challenges that we have identified through the course of our work, and this is through environmental scanning, key informant interviews, reviewing the literature, that there is little consistency in attribution models across payment programs and payers, and there's a lack of transparency both for physicians and patients as to how attribution models are designed and implemented. Many of the models that were identified through our work used retroactive attribution. We talked a little bit about the differences between prospective and retrospective attribution earlier. But this also brings up questions over what the provider's locus of control is as we shift to population-based models and outcome measures. And we also found through the course of our work that there has been some research to show that depending on how the attribution model is implemented and what decision rules are specified within the model, that it can impact a provider's performance results, and sometimes significantly. Next slide. So to address some of these concerns, many of which have played out in our work at NQF, at our tables with our standing committees reviewing measures, we sought to explore this issue in a lot more detail and across 2 projects that focus on advancing our understanding on attribution and hopefully contributing to the literature based on this topic, as well as providing guidance to the field on how to start to think about attribution and its application for within value-based purchasing. So we did work in 2 phases. In the first phase, again, it was triggered by some challenges that arose in the endorsement process of quality measures, particularly where there was a measure in particular that was attributed to a hospital, but included costs that were primarily accumulated after the discharge of a patient from the hospital, and accumulated costs that were acquired by the skilled nursing facility and other costs in the community up to 30 days after the end of the hospitalization episode. And so there was a lot of discussion of whether or not that was an appropriate method of attribution. So within that first phase, we also sought to establish the foundational understanding of the concept of attribution. How do we define it? What's included in an attribution model? And what's the current landscape? And how are folks really doing this work on the ground? And the second phase, we sought to build on the work of phase 1 and really try to address some of the challenges that we weren't able to get to in the first project. And we're really looking to provide some more practical guidance for selecting attribution approaches, and really focus around some key ideas or elements that should be focused on when selecting an attribution model for your purposes. You'll also note at the bottom of the slide that the reports for these 2 efforts are linked at the bottom of the slide. I definitely encourage you to download them and read them over. They are quite dense, and so, but do include a lot of really good information, and so hopefully you'll find those useful for any additional details that I'm not able to cover here today. Next slide. So in phase one, again, we were looking to identify some of the key challenges that exist with determining attribution approaches. We were really looking to identify the key elements of an attribution model, understand some of the strengths and weaknesses of different approaches, and establish a set of kind of foundational guiding principles that folks should be using when they're going through this process of developing and implementing attribution models. And finally, I would say the key output of that first effort was our attribution selection guide, which is a tool that was developed to provide guidance for selecting and implementing an attribution model. And I'll talk a little bit more about that later on in the presentation. Next slide. So some of the key findings and challenges that we found through the first phase, just a little bit of background here. We did work with a researcher out of the University of Michigan to help us conduct an environmental scan of attribution approaches that are being used on the ground across healthcare systems, health plans, local collaboratives, and hospitals, and any other healthcare entities that we thought might be implementing attribution for their particular purposes. And so some of the key findings that we had were that, you know, there really are no best practices, that everyone is kind of employing their attribution approaches to the best of their abilities and their knowledge for their particular population in their particular setting. There's no standard definition for what an attribution model is, or what elements it would include, or what steps or decision steps it would include to make it an attribution approach. And so, again, lack of standardization across the models, which limited our ability to do head-to-head comparisons because they were so different. We did find over 160 models that were either proposed in the literature or by other users, or that were actually in use. And so you can see here, only a small percentage were actually in use, about 17%. Most of them used retrospective attribution. And then again, most of them also attributed to a single provider, most of which was to a physician. Again, little consistency, and we've talked again earlier about how changing the attribution model and the rules or decision rules within the model can alter the results of a performance measure or a attribution within the program for the attributable entity. And finally, one of the key takeaways was that there was a lot of lack of transparency for those who were being measured around how the attribution model was designed, how it had been applied, and whether or not there was avenues for the attributable entity to appeal the decision or outcome of a performance measure or the attribution approach where they felt they had been wrongly assigned responsibility for a patient. Next slide. So I wanted to just talk a little bit more about some of the approaches that we found during the environmental scan. So here, most visits versus the majority of costs. So just a little typo there. But again, plurality of visits means that attribution was being applied based on a patient having the most visits to a particular provider. Another approach was that they might attribute a patient to a provider that was accountable for the most cost within that measurement year or within an episode, which can be very different. Again, we've talked about prospective and retrospective attribution. And again, this idea of attributing to a single provider versus multiple providers. There's team-based attribution, where a team is attributed the care of the patient. And this team could be providers that were that provided care to the patient within the episode that may or may not be associated to each other, but are teamed just based on their association to the patient. Another approach in terms of attribution to multiple providers would be the assignment of accountability evenly across multiple providers. Particularly, probably the easiest way to think about this would be within a cost measure where there may be a cost for an episode, and regardless of cost, that each provider within that episode is equally assigned responsibility, so they're all the primary or equally assigned accountability for that episode. And then another way of thinking about this attribution to multiple providers would be to divide costs across the providers based on their billed services. So again, depending on the amount of dollars that were billed for particular services within that episode, that each provider would be accountable then for the cost that they directly billed. Another approach that was identified through the scan was patient attestation. And this is when the patient is actually asked directly who they believe to be accountable for their care. This we found to be used often in conjunction with other attribution methods to ensure that there is some patient involvement or voice within the attribution, the development of the attribution model or decision-making process. And then finally, there are also assignment to established provider units, which we're all familiar with, assignment to group practices, hospitals, and ACOs. Next slide. So this slide lists our guiding principles that were established with this effort. I won't spend time on each one individually, but just kind of to lay them out for you, that we did determine that attribution models should fairly and accurately assign accountability, that they are an essential part of measure development, implementation, as well as policy and program design, and that the choices that are considered among the available data are fundamental to the design of an attribution model. They should be regularly reviewed and updated. That model should be transparent and consistently applied, and they should align with the stated goals of the purpose of the program. Next slide. So this slide illustrates the attribution model selection guide. And this is the guide that I referred to earlier. It's a tool that we developed as a part of the first phase of the work to help guide implementers and those developing attribution models through a logical and systematic thought process to help them consider the decision rules within a particular attribution model that they may be developing for their purposes. So there's 4 kind of domains of questions or areas of questions. The first is around the context or the goal of the accountability program. The second is around how the measure relates to the context in which it's being used, who are the entities receiving attribution, and how is the attribution performed. So again, within each of these domains of questions, there's a set of questions that are to be considered by the implementer or the developer of the attribution model to help them think through some of those tough questions and help determine the decision rules for their particular purposes on how the attribution model should be developed. I will share a couple of things in terms of feedback that we've gotten back from this guide, and we're certainly open to additional feedback and hope that those who are listening and are able to access the guide will feel free to reach out to give us additional feedback, as we are looking for ongoing input to improve this tool. Some of the feedback that we've gotten is that the tool wasn't directive enough, so there's a lot of open-ended questions that are really designed to have the person who is implementing the attribution model make decisions and answer the questions based on their particular purposes. And what we found through this work is that our experts on the committee really had a hard time providing really directive guidance on, for example, what attribution approach should be used for this particular type of program, because often there are nuances or specific details about particular applications which oftentimes the answers to those questions are, it depends. And so there was a real desire for the committee, for the expert panel that we convened for this work, to provide the guidance, but without being overly directive. And what we found when putting this work out there is that folks really wanted that directed guidance so that they would know that they were using the right approach. And so, again, there is this tension between the desire for clarity about the attributions model fit for purpose and the state of the science related to attribution. So there wasn't really a lot of evidence or literature out there to back up any specific recommendations on model selection or decision rules for attribution. And so again, there was a hesitance there from the experts to really make specific recommendations for guidance there. So again, the purpose of this is to aid measure developers and hopefully to improve standardization such that our approach to attribution going forward is more consistent across developers and those looking to implement attribution. Next slide. And so some of the recommendations that came out of this work, again, build on the principles and the attribution selection guide, but that we do recommend use of the guide to help, again, promote consistency and to help you think through those important trade-offs that you might be making with making certain decisions within the attribution approach, and to evaluate the factors that you would consider when you're developing that approach. Also, that attribution models should be tested, that there should be some effort to determine the number of patients that are attributed when you apply the attribution approach, and also to go back and look to see whether or not those patients that were attributed based on the application of the algorithm or the attribution model, that there is some relationship that can be determined through either documentation or through follow up with the particular provider, that the attribution model actually is performing the way it is intended. Again, that there should be some multi-stakeholder involvement in the selection and the development of the model. This would include those attributable providers or clinicians that are included in the model, such that they have an opportunity to provide feedback on the model before it is implemented. It may also include patients and consumers. Also, there was a recommendation that models should be attributed to entities who can influence care and outcomes. And again, one of the main points that the expert panel wanted to make about this recommendation is that for those attribution models that are determined to be aspirational, where on the surface it may appear that the provider does not immediately have locus of control of the patient outcomes or cost for that particular measure or episode, that it's clear that this is an aspirational approach which is designed to drive collaboration or care coordination or communication with providers that may not otherwise be doing that, which it is intended for that model to actually help those providers collaborate in order to lower costs and improve quality. And the final recommendation is that attribution models that are used in mandatory public reporting or payment programs should meet a minimum criteria. And so this final recommendation is what triggered our follow-on work, which we'll talk about in the next slide. So in our second phase of work, again, was building on the first phase, and we really wanted to, again, address some of the issues that we weren't able to cover in the first project. We wanted to hopefully, again, contribute to the development and dissemination of some best practices for attribution, offer some key considerations for evaluating attribution models, and hope to establish some of those criteria that we alluded to in the recommendations for the first project, and hopefully inform quality reporting and value-based payment models for both public and private sectors. Next slide. So some of the challenges or key issues that we focused on in the second effort were the unintended consequences of attribution, data integrity and collection, attributing complex patients in special populations, which include children or those with multiple chronic conditions, attributing an environment of team-based care, testing attribution models, what does that mean and what does it look like? And then we also wanted to do some focused work on how we can improve the attribution selection guide to make it a more useful tool to those who are doing this work. Next slide. And so this slide summarizes some of the findings and some of the evaluation considerations that the report for the second effort is really framed around. And so I will just note that each of these items, while seem short on the slide, are actually, there's a lot of information behind these. So I am going to give a very high level overview of these evaluation considerations, but encourage you to review the report in more detail if you have an interest to do so. So in the first evaluation consideration, again, that the assignment of accountability to entities that can meaningfully influence results. Again, this consideration is around ensuring that those assigned responsibility have the mechanisms or the direct communication or interaction with the patient in order to improve the quality or cost of care that is developed. And with model testing, with the second evaluation consideration, would look specifically about how the model has been tested, what proportion of patients are attributed. The idea is that that we should be attributing as many patients as possible, such that those patients who are attributed, actually there is someone who's responsible for their care and therefore responsible for improving cost and quality. And so the idea is that any evaluation of the testing approach should highlight that there's been some evaluation or effort to determine the proportion of patients that are captured with the attribution approach, and also to compare other attribution approaches. And the idea here is that we want to encourage people to not just select one attribution approach and decide that that's the way to go, but to explore other approaches and other models and other decision rules that can be potentially used to see whether or not you're getting more optimal performance of attributing patients and attributing them accurately and fairly with other models vis-a-vis the one that was selected. The third evaluation consideration is around the data that is used to support the model. So the discussion here is around, identifying the different types of data that can be used to determine the relationship of the patient to the provider. That may be clinical data, that may be encounter data, exploring the use of EHR data and other types of data that may be evolving as administrative claims may not always give the detail and the specificity that is desired, particularly when assigning accountability. Again, this idea of aligning the attribution model with the context of its use, particularly that if you're attributing a model, or your attribution model is to attribute to a hospital, that the program, for example, that it is implemented in should also be aimed at assigning accountability to hospitals. And then there's some thought of the alignment not only of the model, but of the measures that are used in the context of its use. That there should also be some accountability, some mitigation of unintended consequences. Some of the unintended consequences that we explored are this idea that that physicians or other clinicians who have not been enabled transparency to the attribution approach become mistrustful or distrustful of the system. They don't trust the results, therefore don't act on them. There may also be an unintended consequence of kind of overly, kind of applying attention and focus on those patients that are attributed to them, or trying to avoid attribution of patients to their profile that they think may bring down their scores or performance results. And so definitely kind of having some thought process or evaluation of what may happen if a particular model is implemented and how those unintended consequences will be dealt with. And again, the idea that transparency to all stakeholders who are being attributed to is accounted for in the way that the model is implemented and rolled out, such that there are avenues for appeals and questions and feedback on the model. Next slide. So that was a lot of information, even in my effort to provide a high-level overview. So on this slide, we just wanted to really illustrate some of the key takeaways. If you think about this in a process around model selection through implementation, reporting, and then feedback, and how that feedback feeds back into the decisions around model selection, and the idea that there should be a mechanism for providing transparency through all those steps as you determine the attribution rules and implementation, and how those results will be reported within your particular system or purposes. So particularly for model selection, we do encourage the use of the Attribution Selection Guide to help you think through some of those key issues. You'll be wanting to think about how you're going to test it and validate it, and to gain any provider buy-in that you would need before or as the model is being selected, such that it is one that they believe in and agree with, and will be taking the necessary steps to improve quality and cost once the model is implemented and their patients and performance results are shared. Within the implementation step, we just encourage you to consider again what data you have available to you, what setting-specific considerations you may have, particularly for skilled nursing facilities or hospitals or settings such as home health care within the community. And that particularly with team-based attribution, if you're thinking about who is going to be on the team, that those teams are clearly defined, and that those team members are aware of the others and who's on their team. Within that reporting step, if you just want to think about to whom the results will be shared. If it's a team, do the results get shared to the whole team? Is there one person within the team that is expected to distribute those results to the other team members? And also to be really mindful of the timeliness of the results. If results are reported to the accountable entities, months or even a year after those encounters occurred, it's really hard to take action or even provide feedback on the accuracy of the attribution when the time lag of those results is somewhat insurmountable. And finally, within that feedback process, again, to be thinking about some of those unintended consequences that may occur through the application or implementation of the attribution approach, and who will have the actionability to improve the quality, and that there is an avenue or mechanism for adjudication of discrepancies by those accountable entities. Next slide. And so with all that, our next steps with this work are to, again, promote the use of the Attribution Selection Guide. Again, we are working on making some improvements to it based on the feedback that we've received to date. And we do hope to do some future work using actual data to better understand and compare measure results and provider performance using different attribution models, and really putting our own recommendation to the test in terms of what does it look like to test an attribution model, and to really demonstrate empirically what it looks like to have a focus on attributing most of your patients and to comparing various approaches and how it affects performance. And then finally, we do hope that as more time passes and with this work and with other literature and other researchers look to provide additional guidance in the field, that we can provide more directive guidance on the selection of attribution models, so that those in the field looking to do this, it won't require so much strife and confusion around what to do in your particular purposes. So we are working on it and hope to get to a point where there can be more definitive guidance. So I think that's it for me, and I just want to thank everyone for joining. And again, if you have any questions, my email information was on the initial slide for this session. Feel free to reach out to me with any questions or comments, recommendations. We're happy to hear them, and I look forward to it. Thank you very much.
Thank you so much, Ashley. That was some great information. And thanks to our listeners today. If you have any questions about CORE's work or specific questions for Ashley, you can send them to the CORE inbox at core@caqh.org, and we will forward them on to the appropriate expert. Thanks again for joining us.